It's time now for Ask the Surgeon, brought to you by Everett Bone and Joint. Everett Bone and Joint, the best choice to get you back in the game. Learn more at everettboneandjoint.com.
And we welcome you back to Integrated Rehabilitation Group Health Matters. Call in with your questions at 425-304-1380 or go to irgpt.com and click on the Health Matters icon and submit a question. Tom Lafferty along with Shannon O'Kelly. Ask the Surgeon brought to you by Everett Bone and Joint. Dr. Peter Kinahan, orthopedic physician from Everett Bone and Joint, is with us, and we're going to discuss rotator cuffs. Shannon, you have to turn. There you go.
I got the mic here. I'm new on this board tonight.
Yes, you are.
Maureen's gone, so I'm running the board. Yeah, we got Peter Kinahan with us tonight. Peter, how you doing?
I'm great. Thanks, Shannon.
Hey, so listen, you're an orthopedic surgeon here in Everett at Everett Bone and Joint. Do you have an area of specialty or interest in your practice?
I primarily look after shoulders and knees.
Okay, shoulders and knees. So you probably work with people that are hurt, working. Do you work with labor and industry or L&I or work injuries type situations?
That's right. Probably about half of my practice is work-related injury, and the other half is probably mostly sports injuries.
Okay, so talking about the shoulder now, we've talked about the rotator cuff and rotator cuff injuries and tears, and we've talked about impingement. Now, from a worker standpoint, someone who's doing probably overhead activity probably throughout the day, how do they injure their shoulders? How do you experience that?
Well, what I like to tell my patients is that when you're young and fit, the rotator cuff is a really strong, thick fibrous tissue, and it takes pretty much some major injury like falling off a motorcycle or something. But when you get older, you tend to develop bone spurs, and the bone spurs can dig into the rotator cuff and gradually abrade or grind their way through. And if you think of it, it's almost like a piece of rope that slowly gets ground through. And then if you have a relatively more minor injury, then you can tear your rotator cuff.
Okay, so bone spurs, now you're developing that. That's a topic, and I'm trying to set this up because we're on the radio anatomically. The spur is on the bone above the rotator cuff, on the acromion we call it?
Yeah, you can either be from the acromion or else from the end of the collarbone at what's called the AC joint.
Okay, the acromioclavicular joint. So if you touch your top of your shoulder and you feel that bony area, that's the AC joint, where the clavicle and your shoulder blade or scapula kind of come together there.
That's correct. Yeah.
And so with those spurs, as you age, and particularly, what about those folks that are doing overhead type stuff? Are they more prone to develop those spurs from wear and tear?
I think especially people that do a lot of repetitive motion, especially things like using heavy drills or riveting, that sort of thing, you can tend to develop those spurs more frequently.
Someone, what comes to mind there when you say riveting and drilling and stuff, someone who does repetitive, someone like a mechanic out of Boeing who's going to be doing multiple drilling and overhead activities on a plane.
Right. It's a really common problem with that situation.
Okay. So they're doing this overhead activity, develop spurs. The spurs are then digging in the rotator cuff, and the rotator cuff is the tissue that holds the shoulder, stabilizes the shoulder joint or the ball and socket.
That's correct, yeah.
Okay. Now, how are you going to diagnose that? What's your typical approach on something like that?
Generally, with any diagnosis, you start off with a history. So, in other words, the story that the patient tells you, then a physical examination, and then investigations. So if you think of it in those three major groups, usually with a history, they would start off with a complaint usually involving pain, difficulty with repetitive over-shoulder use, sometimes pain laying on that side at nighttime, or even laying sometimes on the other side, sort of allows the shoulder to roll over and sort of pinch in.
Okay, so again, the spurs and the bone are digging into the tissue, and so you're going to take a history. You're going to find out, is this something that's generally chronic in nature? Do you find it being more chronic, or
it can be, or sometimes it's intermittent. Sometimes people they'll come in and they'll say, oh, I had an episode like this 6 or 7 years ago, got a cortisone shot, and I got better, and now it's bothering me again.
Okay, so diagnostically, are you, because it's a bony spur and it's soft tissue, are you going to approach it with an X-ray? And let's talk about X-ray versus MRI for this problem.
All right. X-rays can be really helpful because the bones show up really well on X-ray. In fact, a lot of patients think that if they've had an MRI, they don't even need an X-ray anymore. But actually, the X-rays show the bone and the bone spurs better than the MRI does. MRI, of course, has just revolutionized all kinds of surgeries, but especially for shoulder surgery, it's been really helpful. There are two different types of MRIs. There's a plain MRI, which is an MRI done without contrast, and then there's an MRI which is called an MRA, and that's when there's been an injection of gadolinium, which is a contrast agent that you put inside the joint through a needle. And that shows up the inside of the joint, and especially rotator cuff tears or labral tears, much better than a plain MRI.
Okay, so let's talk about the labrum. Now set us up anatomically. What is the labrum, and why is it important that you look at that in these type of injuries?
The labrum is a cartilage that's inside the shoulder, and many people know someone who's had a torn cartilage in their knee, and that's such a common problem, and I try to relate it to that. And the cartilage inside the shoulder is a little different. And if you think of it anatomically, the shoulder is made up of a ball and socket, and on the socket side, if you sort of think of the socket, if you're looking right at it, and you look at it like a dinner plate, it's sort of like that rim all the way around the dinner plate.
And that's the labrum.
And that's called the labrum, and it's a piece of cartilage that has really poor blood supply. Okay. It's a beautiful white, shiny, pearly type of cartilage. And once it's torn, unfortunately, it won't heal itself because it doesn't have any blood supply, so it doesn't tend to heal.
Okay, so that's important to that concept. Lack of blood supply in that cartilage is the reason why it doesn't heal.
That's correct.
And we kind of hear that, and that's the similar thing in the meniscus, the cartilage in the knee. So these cartilages with that blood supply aren't going to heal on their own.
That's correct.
Okay. So now when you do an MRI and versus an X-ray, now I have a lot of patients that come in and I say to them, what kind of diagnostic test have you had? And they'll say, I had an X-ray. But I don't think people realize that X-rays aren't looking at what we call soft tissue. X-rays are looking at calcification or bone, right?
Right. And so sometimes in the shoulder that'll be helpful if people have calcium deposit in the tendon or calcific tendinitis, or if there's a tumor or cyst in the bone. And it can be helpful for ruling out other causes like either arthritis of the main ball and socket joint, and sometimes usually you can see the bone spurs if they're present.
So just so everybody knows, X-rays are going to look at bone. If you want to take a little deeper look at the soft tissue, the labral, cartilage, rotator cuff muscles, tendons, you're going to order the MRI.
Correct.
And so you have two options on the MRI or the MRI with contrast. Now, when would you use those to differentiate between those two?
That's a really good question because you don't really want to arrive at an orthopedic surgeon's office with the wrong test already having been done. Usually in an older patient, and I'm almost 50 myself now, so I get that.
I'm right behind you. I'm right behind you. Tom, where are you at?
Careful. Some of us have gone past the door.
That keeps changing, right?
Yeah, exactly. Yeah, you're 39, right?
Yeah. Anyhow, but I would say generally in people who are, I would say, age 60, 65 or a bit older, you would generally just get a plain MRI because there you're concentrating more on the rotator cuff. Younger patients, especially with athletic injuries, I would tend to get an MRA, or especially if somebody's already had shoulder surgery before and it's a more complicated situation, then normally you would get an MRA, go ahead and get the test with the enhancement dye inside the joint.
Okay, so now you've made the diagnosis. You have let's diagnose it as an impingement with spurs, and the surgical intervention needs to take place. What are the options at this point in time?
So generally, of course, you would try conservative management with either physical therapy, anti-inflammatories, especially therapy and strengthening the rotator cuff can be helpful because even in the presence of bone spurs, sometimes those treatments can help. Cortisone shots can be helpful as well. The other, generally, when you get past that point, if months have gone by and you're really having problems with pain and dysfunction, generally you would consider doing an arthroscopy of the shoulder, which is the little keyhole surgery. It's minimally invasive type of an operation, and with that we can then diagnose and look at the different areas both above the rotator cuff and look at the bone spurs, look at the rotator cuff itself from the bursal surface, which is the top surface, and then also look right into the ball and socket joint. And at that time, you can look at the rotator cuff, the biceps tendon, the labrum, and the joint surfaces, and just see if there are any loose bodies floating around or any tearing of the tissue.
Yeah, so just for those listeners, what you're talking about is you basically are inserting a camera into the joint, and you're using that camera to explore, and then through that camera you're looking on a monitor as you're doing the surgery, and you're just scoping and looking and exploring and looking for the pathology, right?
That's correct. And then once you've made your diagnosis, sometimes you can do the surgery through the scope, and I'd say probably about half the time, depending on the type of treatment. So, for example, a labral tear, maybe related to somebody's shoulder dislocating over and over, or different types of injuries, that frequently can be repaired completely through the scope.
So how are you repairing that? Are you suturing it? Are you stapling it? Describe, how do you repair that labrum without a blood supply? Are you resecuring it? Talk about that a little bit.
Yeah, it's quite interesting because you're trying to suture down a piece of cartilage onto the bone without where you have very little access, and it's 3 or 4 inches inside the body. Generally what we do is we put a drill in through a cannula, and we drill a 3 millimeter hole that's just deep enough for a little anchor. We tap that into the bone, and then we pass one, and then the anchor is attached to some stitches, and the stitch is fabulous. Shannon, that stitch has a Kevlar core. Same thing they make bulletproof vests.
There you go.
We're going to give you a bulletproof shoulder. It's awesome. And then you pass that suture through, one limb of the suture through the torn cartilage, and you tie the knots outside of the body and slide those knots in and secure that cartilage back down.
That's pretty amazing technology. The scopes now. How long ago? Maybe as of late as 5 years ago, you didn't have that option in the shoulder, did you?
The technology continues to evolve. There have been some earlier products that we don't use anymore because they just have proven not to be helpful. A lot of the new instruments that we use bioabsorbable implants. So instead of putting a piece of metal inside the bone, we're putting a little element in that is actually made of sugar.
Wow. And okay, so Tom, go ahead.
We're talking with Dr. Peter Kinahan, orthopedic physician from Everett Bone and Joint. Call in with your questions at 425-304-1380. I have a question. You talked about sudden injury. So if I get thrown off my motorcycle, or I've been sheetrocking for 25 years, is it 2 different surgeries? Or do you not know that until you get in there?
You really don't know till you get in there.
Okay.
And it's interesting. I frequently tell my patients that there's no date stamp on the inside, so it can be difficult to tell. And a lot of it ends up being based on the history. So what the patient tells you is basically, sort of your clues to help figure out what's going on.
So that's a good question. A lot of times, but for those folks that do repetitive work overhead for many, many years, they may have a tendency to be more prone to some type of impingement or calcification or bone spur just from the wear pattern on the shoulder.
That's correct.
Yeah. So take us back to, because I'm fascinated with this arthroscopy, and they're doing it now in the shoulders, they're doing it in the ankles. Almost every body part can now be scoped. So those kids out there listening, make sure you're good at your video games because it takes you a long way, right? So you got to be pretty good with your hand and eye coordination. But talk about the bioabsorbables. These screws and these anchors that you're putting in. What do you mean bioabsorbable and made out of sugar? How does it hold anything?
It's really incredible. The technology has improved so much, and when I was in my training as an orthopedic surgeon, we always were a little timid or frightened to put screws around the shoulder because they tended to loosen up.
Back out.
The screw would back out and then could get loose and could get into the joint and cause third body wear and get arthritis. So the number one thing, you don't want to cause a worse problem than you started with.
Right.
With these bioabsorbable implants, what happens is they end up actually rigidly holding in place, and then the body gradually comes, and over a period of a year or a year and a half, the little white blood cells come in and they gradually eat the implant up after it's no longer doing its job. So
the screw is there, the absorbable screw is there to hold temporary anchor, and then what happens is your body then scars down and takes that over, the screw absorbed by your body, and then you're back to kind of where you were prior to the surgery almost? Yeah. The other advantage of it as well is that later on, if you're having a problem and you need to get a new MRI, the MRI can be degraded by having metal present. Right. So another advantage of the bioabsorbable screws is that basically they're gone, and so you can get an MRI without any problem. Yeah, you and I were talking earlier, and you had mentioned that sometimes you've had patients that had an MRI and it didn't show a pathology, but then, you went in with the scope and you found. Tell us how that kind of happens. Are all MRIs positive, or how does that work?
That's a great question. There's unfortunately, with any test, there's an incidence of false positive and false negative.
Okay. And,
ultimately you're looking at different hues of gray and different hues of white on the screen or on the video monitor, and you can have a labral tear and have it not show up on an MRI or an MRA. And we've seen that over the years where patients come in with a really convincing story of an injury. They have a positive test when you examine them. It suggests that they have a tear, and then they have a negative MRI. And after trying various conservative treatments, if they continue to have symptoms, sometimes you take them to surgery and scope them, and you find that in fact they do have a substantial labral tear or torn rotator cuff.
Okay, so fascinating stuff. Dr. Kinahan, thanks so much for your time and your expertise. I mean, it's amazing what the technology is out there, and I assume that just over the next 2 years it's advancing so fast that you guys are constantly studying to keep up on all the technology. So,
Shannon, it's like you. There's always something new to learn.
Yeah, absolutely. Well, thanks again for your time. And if you have a question for Dr. Kinahan, you can go to our website at www.irgpt.com. And you guys have an MRI facility at your location, right?
We do.
Okay. Thanks, Dr. Kinahan.
Thanks so much, Shannon.